Okay, so I'm back to recording again, and we kind of finished with this slide at the end of the last presentation, and we are going to finish Learning Plan 3. So again, just to recap what I said at the end of the last slide, basically, or the last presentation basically, is that we really have to think about our LGBT, actually, and there's a longer kind of an acronym for people that have different types of gender identities. And so we really have to think about, and that probably that is even growing. There will continue to be change and growth in the way that people describe their sexual identities. So we really do have to think about how vulnerable that these people are to bullying and to just being excluded from friends and family members, and just not being basically given the same rights as other human beings are. And so those sexual minority youths more likely to report suicidal ideation. And if you think about what goes on during adolescence anyways, that people are more likely to have difficulties even in just kind of trying to find themselves and figure out who they are, and just kind of dealing with life and people in general. That can, and then if you have a sexual difference like that, it's just only going to compound matters for these people as far as them becoming suicidal. So we have to look at some cultural factors and think about protective factors. So those are the types of things that would prevent people from committing suicide. So many times the protective factor for being African American is that many people have strong religious, again, we can't stereotype or typecast people, but traditionally have had strong religious views, and they have the role of the extended family in terms of providing support for all family members. So extended family and friends and just having that nice tight-knit social network can be very helpful and protect people from committing suicide. And Hispanic Americans also, their religious views, and again, the importance of the extended family and really being connected to each other, multiple generations all connected together. And then also Asian Americans may have adherence to religions that tend to emphasize interdependence between the individual and society. So you wouldn't want to let society down because of your own individual needs. However, in the Asian culture, it does talk in your book about sometimes there is that belief about preventing shame. You don't want shame to come to your family, and that suicide might be considered more honorable than having your family undergo shame. So, there is a little bit of that aspect also that we might have to think about in the Asian culture. So if anybody is of Asian descent, it would be really interesting if you could weigh in and shoot me an email as to what you think about that and maybe what your own experiences have been. Or any of the other cultures, actually, any other cultural group. That would be very interesting to find out firsthand experiences. So societal factors. So we have to look at what are we like as a society in general. There are places that have assisted suicide, and certainly in the Netherlands, Belgium, Switzerland, some of those countries have had legal assisted suicide, for many, many years. And in the United States, there's a lot of different thoughts and feelings about that, and apparently the individual states can allow, regulate, or prohibit assisted suicide. And of course, there are many differences among the states. So we do have to kind of think about some of the things that are happening in our society. And of course, the biggest societal factor that they talk about in your book is that people, besides assisted suicide and suicide bombing and things like that, the biggest societal factor, one of those, is that we are becoming more socially isolated. We tend to text people rather than call them and talk to them personally. We drive to work alone. We so value that being independent and relying on ourselves, that's maybe sometimes we don't even make eye contact with people, or we just don't associate with people as much as we used to in the olden days. So today, maybe neighborhoods, people don't even really know each other very well, And in the old days, everybody knew. You always knew your neighbors. You knew neighborhood kids would play together. And it just seems like people are a little bit more isolated these days. And of course, that type of isolation can lead to people having difficult types of moods, depression, and then would increase suicide. So suicide bombing. So the DSM-5 really excludes religious and political suicides from its criteria, because the goal of suicide bombing is that people feel like that is a noble thing to do, that by sacrificing themselves for the greater good, somehow they are going to, enter into the next life triumphantly. That's kind of the thought process that goes on with a suicide bomber. So they really don't fit the criteria. When we're talking about suicide, we're not talking about people that are that have performed suicide bombing and have died that way. So the clinical picture risk assessment, we have to look at suicide attempts. So a history of attempts increases the risk of a completed suicide. So when we're sitting in report and we hear that somebody has had 5 suicide attempts already, oh my goodness, that is a huge risk that one of these times, maybe the next time, that they are going to have an actual completed suicide. So on an average, only about 56.4, so a little more than half of reported attempts received adequate mental health treatment. There are times when I hear about people that have overdosed or cut their wrist or something, some kind of a suicide attempt, and they really have not gotten proper care. Maybe they pumped their stomach and whatever, gave them some resources, and then discharged them back home again, and didn't even really admit them. Even admitting them like for 24 hours for like a hold and for observation. Sometimes people just don't get the care that they need. It's possible that they refuse it, but honestly, most states have some kind of an involuntary admission process, which we call in Wisconsin is a Chapter 51, where people can be admitted even if it's against their will. But if it's to save their life, it certainly would be valuable to try to hook that person up with treatment before they go home and perhaps make another attempt. So there is something called suicide behavior disorder in the DSM, which basically is again, diagnostic statistical manual. It outlines and gives criteria for every single diagnosable mental illness condition. So an attempt within the last 24 months, the attempt was not initiated in delirium or confusion, and an attempt was not undertaken for a religious or a political objective. So really, most of the time, most people that have suicide attempts aren't delirious, they're not confused, they really are aware of what they're doing, but of course they're heavily influenced by their mental illness, whether it's major depression or schizophrenia, something like that. So, application of the nursing process, of course, we do have to look at verbal and nonverbal clues that people give us when they are suicidal. And when you are in clinical, I will do a presentation for you and give you a certificate, and it's called QPR, which is Question, Persuade, Refer. And we do go over a lot of this information in that, and you will actually then become a community gatekeeper, somebody who is certified and able to assess people in the community and actually get them to help, and maybe you'll feel a little bit more comfortable with the whole idea of suicide after you get that training. But anyways, we really do have to look at verbal and nonverbal clues, because sometimes people will overtly make statements like, I can't go on anymore, life isn't worth living, I want to commit suicide, I don't want to be here, I'm going to end it all. So some people are very direct about those statements, and some people say things that are just a little bit more, just like a little bit more, not really secretive, but just maybe more subtle. So saying things like, things will never work out, it's okay now, soon everything will be fine. So in other words, they're kind of giving you like hints and clues that perhaps something is coming on. So we do have to address, when we are working with patients, we have to address some of those clues very clearly. So when they say something like that, like, I won't be a problem much longer, what do you mean by that? Can you tell me more about that? And then very directly, we might have to say, are you thinking about killing yourself? And hopefully that person will be honest. If they are still wrestling with their decision, because many times when people are suicidal, they don't just come to that decision instantaneously. Many times people wrestle and struggle over that decision for a long period of time. When they are no longer struggling with that decision and they've made a firm decision and they feel comfortable with it, that's at the point in time when they may not be honest and tell you how they're really feeling. But up until that point, if they're still struggling, most people are very open about talking about their suicidal feelings because they really want help. They don't necessarily want to die. They just want their pain and their suffering to end. So we do have to look at the clues, verbal and nonverbal. We also have to look at the lethality of their suicide plan. So things that are considered highly lethal would be using a gun, jumping off of a high place, hanging, poisoning with carbon monoxide, staging a car crash, and things that are lower risk or soft methods could be cutting your wrists, inhaling natural gas, ingesting pills, so overdosing on, pretty much just about anything. Although honestly, overdosing on Tylenol is a very serious, deadly overdose. So if somebody takes a bottle of Tylenol, maybe they're discovered in time and they're able to give them medications to counteract that. But boy, that is a very lethal overdose also, is overdosing on Tylenol. So even though it's not listed as a, one of the lethal methods, we do have to kind of keep that in the back of our mind that is a very serious overdose too. So, and if we also have to look at, do people have the means to carry out their plan? So all of those are very, important things to look at. And again, like I said before, if they are practicing and rehearsing some of the things, looking things up on the internet, then we know that they're really getting very serious about their plan. And again, we always have to do that self-assessment because there are many people that really feel that suicide is a choice and that people are being very selfish, and that, again, it's a moral failure and it's a character flaw if they're feeling suicidal. So if we feel like that as health professionals, we're not going to be very effective to helping people to save their lives. So we always have to do that self-assessment. And if you're struggling with feelings like that, like people are selfish or they're weak, whatever, then that's at the point in time where you need to either get somebody else to do that assessment or get some supervision and get some help for yourself so that you understand why you're reacting like that and that you can react in a little bit of a different way. Little bit of a discussion question. You are worried about a close friend who recently broke up with a boyfriend. She's taking the breakup very hard, seems depressed. What are some questions you could ask to assess for a suicidal ideation? So I'm hoping that you're going to say some of the things that we just talked about. Do you have a plan? Are you feeling suicidal? Do you have a plan? Do you have the means to carry out the plan? And how much have you thought about it? Just really to try to get people to talk about it as much as possible. So I think they really give you a really good example of some of this on page 479 in your Varkarolus. They go through the verbal and nonverbal clues. There's lots of them. And then talking about the lethality of the plan and the self-assessment. So really the readings very much are very important for your thorough understanding of this. So yeah, health professionals might experience fear, grief, anger, puzzlement, like how could anybody even think about that? Because maybe if you yourself have never felt like that, if you're a pretty happy person, you might even just be confused. Why would people feel like this? So, or just condemning people. They must really be bad. They must be a bad person. They must be very selfish. So again, we really have to be careful about that. So some nursing diagnoses that apply. Absolutely risk for suicide. That should be a number one high priority diagnosis when anybody has any type of suicidal ideation, whether it's passive all the way up to having a plan. Self-care deficit, again, when people are depressed, they many times have suicidal ideation, and then they're going to be not really taking care of themselves very well. Sleep pattern disturbance, so all of the symptoms of depression that we kind of talked about already. Altered nutrition, they're usually not eating very much, and again, very much depression and anxiety go hand in hand, both very much comorbidities with each other. So outcomes identification, so we really want people to use self-restraint and not follow through on their plans, either to self-harm or to actually commit suicide. So we really need to look at the whole nursing process when we're working with that suicidal patient. So we need levels of prevention, activities that provide support, information, and education to prevent suicide. So that would be like primary prevention. Providing treatment of the suicidal crisis and actually screening for suicide would be secondary prevention. And then tertiary is the interventions with the survivors left by the person who completed suicide to try to reduce the traumatic after effects. Because now, if you are a survivor, if you have a close person to you that committed suicide, that puts you automatically at risk for suicide. So to work with those survivors is very important because we don't want them to now try to complete suicide also. So psychosocial interventions, talking to the person, listening to them, encouraging them to talk about their thoughts and their feelings, doing things to help with their self-esteem, giving them medications, doing medication teaching, assessing for side effects and for a positive response to meds. Actually, the other thing that kind of goes along with managing medications is that we have to understand that sometimes medications can, in and of themselves, increase suicidal ideation or cause suicidal ideation in a person. But if somebody is taking an antidepressant, we have to keep in our mind that there is a point where perhaps they're so depressed when they're first starting their medication that they have some suicidal thoughts, but they do not have the energy to follow through with committing suicide or even making an attempt. But now they're on an antidepressant, and as the antidepressant starts to work, there comes to a point in time where it's really kind of dangerous because they're still depressed. The antidepressant is helping them to feel a little bit better, gives them a little bit more energy, but because they're not all the way better, their mood isn't completely good, they still are depressed. Now they have the energy. That's a very critical time to assess the patient for following through with their suicide. So that's one of the dangers of the medication that we have to watch very carefully for. Now all of a sudden they have the energy to commit suicide because they're just starting to get better, but they're not all the way better yet. Very important thing for us to keep in our mind as we help people in this capacity. So again, safety and teamwork. We all need to work together to provide for safety and prevent people from making suicide attempts on the unit or even in the community. Health teaching, health promotion, possibly case management if they have complex healthcare needs, in addition to their depression and suicidal ideation, and if they have a need for somebody to kind of coordinate different types of services for them. We always need to document very, very carefully, and we document what the person says. We can put it in quotes, and what our assessment is, what our interventions were, the response. And if somebody is not able to, one thing we do a lot is contract for safety. If somebody can't contract for safety, we really better be putting them on a one-to-one and documenting that very, very carefully. Or if somebody makes a suicide attempt on the unit, we really should be putting that person on a one-to-one. And when you're on a one-to-one, you are within arm's length of the patient at all times, and your eyes are on the person at all times. You're not looking down at your cell phone. You're not doing puzzles. It's really boring to sit and do a one-to-one. Maybe some of you have had that experience. Yes, it's kind of boring. You're just sitting there. However, it's really important to keep that in mind, because there are times even when somebody is on a one-to-one, and if that one-to-one person is not paying attention to the patient can actually complete self-harm during during being one-to-one. So that aspect of care is pretty important. Postvention for survivors of completed suicide. So if somebody did happen to complete suicide, working with the family members to try to help them to deal with the after effects, because it's really pretty devastating to survive that kind of a loss. And community support groups can be very helpful for family members and friends of people that have completed suicide. So environmental guidelines, and we do lots of these things on the unit. Well, and most of these are coming from the book, but I'll kind of go through and tell you what we do on 1K versus what the book says. They don't use plastic utensils actually at all. Patients are not allowed plastic utensils. In the dining room, they actually have metal utensils, but those are counted. So they're only given metal utensils to use, and it's a butter knife, not a real knife, but it's still a butter knife, a fork, and a spoon, metal, and they do count them, and they are only allowed to use those in the dining room. So if they need to eat something in their room that needs a spoon, they do not use plastic spoons at all. Those are not given out to patients. They use a styrofoam scoop, which is something they cut out of a styrofoam cup, and at least the person can't harm themselves with that. No private rooms. Well, we do have some. Yeah, actually we have all of our rooms pretty much are private. There are some double beds in some rooms, but it's very rare that we will have people have a roommate just for other reasons of privacy. So there are private rooms, but they're suggesting no private room, but keep the door open at all times. They don't really do that on 1K. That would actually be ideal, even to keep the door open a crack, but they do allow patients to close their door. But we do 15-minute checks. We are knocking on the door every 15 minutes and checking on that person. Jump-proof and hang-proof bathrooms, that is something that they have been working on in the unit, and they continuously are doing construction to try to help that issue, and they've done many very positive changes to the unit to prevent people from hurting themselves on the unit. Monitor for and remove potentially harmful gifts. So, well, an example of that, I guess, one thing would be that we just did last week. Well, we didn't do. Security had to, and staff had to do a room search, and they actually found a patient not only was smoking and had cigarettes and matches, but a visitor had also brought them a syringe and a tourniquet. And I'm not sure what was in the syringe, but I would guess it would be heroin because the person was going through opiate detox. So we do have to be very careful. And even with our best efforts, and they've got a really nice system for kind of screening visitors, there are still times when people can, be sneaking in razor blades, matches, lighters, all kinds of things that could be harmful to the patient. So in the patient's presence, assess belongings and search patient room for harmful objects. You always want the patient there when you're doing a room search because you don't want them later accusing you of possibly stealing something. So you have at least 2 staff members and the patient is right there, so that and then you document very carefully. This way, if the patient does say, hey, the staff stole my belongings, then you've got verification that did not happen. So all right, ensure that patients do not bring or leave harmful objects. So that's actually a good point, because there are times when the housekeeper is doing a thorough cleaning of a room after a patient has been discharged, and the housekeeper is finding some strange things hidden in odd places, like they're leaving something for the next person, like lighters, matches, other types of contraband, drugs. So we do have to be very careful about that. So years ago, when I was working in New York, I remember a patient who was a young male, and he was very, very suicidal and very distressed. He would always be pacing the hallways, wringing his hands, and was constantly struggling with suicidal ideation. And I remember talking with him one evening, and boy, I just could not get him to contract for safety. So finally, after spending a long time with him and just really trying to work with him to cope better and cope differently and see some hope for his future, finally he said, okay, I'll contract for safety, and I'll even give you my knife. He had had a knife hidden in his room that nobody knew about. So somehow, when he got admitted, that was missed. So it is really important when people are admitted, and then even periodically through the course of their hospitalization, just to be very aware of if they could possibly have contraband, especially brought in by visitors. But somehow I think he brought this in on admission and it was completely missed. And yes, he gave me his knife. It was a huge, like a butcher knife. It was a big knife. It wasn't just a little small like knife you'd use in your kitchen, like a little paring knife or something. It was a big knife. So very alarming to think that this kid had a knife that he could have easily killed himself right on the unit. So we have to be very aware of our environment. Okay, case study again, back to Gina. Gina's hospitalized with suicidal ideation after 2 suicide attempts. For the first 2 days of hospitalization, she ate 20% of meals and stays in her room between groups. By the 4th day, the nurse observes that the patient is more social, eating meals, and has a bright affect. So, considering her behavior on the 4th day of hospitalization, which factors should the nurse consider? A, the patient's showing improvement and may be ready for discharge. B, the patient may have decided to commit suicide. The nurse should reassess suicidality. C, the patient's feeling rested, supported by the therapeutic milieu, and less depressed. And D, the patient is benefiting from the antidepressant she's been taking for 4 days. So, I hope that you picked B. That is the correct answer. So if somebody goes from looking really bad, really depressed, to looking really good in a very short amount of time, it's probably because they are no longer struggling with the decision to commit suicide. They have made a decision, they feel at peace with their decision, they feel comfortable with it, and they are going to act on their plan. Unfortunately, at this stage, many patients will not be honest, and if you tell them or you ask them if they're suicidal, they're not going to tell you. They're going to say nope. They're going to just completely deny it because they're at that point where they don't want anybody interfering with their plan. But I do think that we should, by reassessing suicidality, I think that sometimes we have to go by our gut feeling and we have to go by a complete assessment. So if they were seriously depressed, they just started on an antidepressant, it doesn't work in 4 days. It would be highly unusual for somebody to go from deeply depressed to feeling fine in a 4-day period. So we know something is not right. And even if the patient denied it verbally, I would still increase my assessment of that person, watch them very carefully, make sure the doctor knows. And then if the patient was asking for discharge, I would absolutely advocate that person does not get discharged because they would be seen to be at very high risk for committing suicide. So that would be a nurse's role because the doctor isn't there all the time, and maybe the doctor is going to say, oh, okay, they're getting better, maybe they can go to outpatient now. Well, no, based on your assessment, you can stop a suicide, you can stop a discharge from happening. So we always have to remember that we have a lot of input as far as what goes on the mental health unit and our assessments, and we should always be documenting and sharing those with the physician. So another kind of a little bit of a separate issue, and we've only got a couple more slides to go, yay, then we're done with their Learning Plan 3. But we have to think about non-suicidal self-injury. So some people injure themselves without the intention to commit suicide. So they are not trying to commit suicide, they are trying to feel better. It is a coping mechanism. It is to reduce their level of anxiety and their level of inner tension and turmoil very quickly, and it's not with the intention of committing suicide. And of course, it is not a very productive way to cope. We want to help them to learn better coping mechanisms. So your book kind of talks a little bit about prevalence, and actually I have seen, and I've read other articles, I've seen patients all the way from childhood, early adolescence, all the way through old age that can engage in self-harm behavior. So we might think about, cutting, burning, different things like that, scraping themselves, just any kind of self-harm, which is kind of, usually fairly superficial, but could be enough to draw blood, of course, or, if people are burning themselves, obviously they're causing, tissue damage. But I have seen all ages engage in self-harm. And about, I think the book says about 6% of the population at any given time is self-harming. That number could actually be lower because many people self-harm and do not seek any help for that self-harm. Perhaps if they have another diagnosis going on, perhaps at some point in time they may seek help for schizophrenia, suicidal ideation, bipolar, eating disorder, or something else, personality disorder. But many times people in and of themselves are not going to be necessarily seeking help, for that type of behavior. And certainly, between 20 and 29 years old is kind of a high point. But honestly, any age and any country in the world, all socioeconomic statuses. It's not poor people, it's not rich people, but it's everything in between. So it really could happen to anybody. Comorbidities, usually other mental health disorders, again, depression, anxiety, eating disorders, personality, substance abuse, so lots of different comorbidities. And usually the anxiety and the psychic tension and discomfort they feel is just so unbearable that becomes a coping mechanism that actually helps them to feel better, even if it's just temporarily. So we do have some, again, the biologic risk factors are going to be that, the same neurotransmitters are kind of come into play, serotonin, dopamine, norepinephrine. So we just always have to think about the role the neurotransmitters play in our mood and our behavior. So environmental factors, we have many different things that we can think about. Your book kind of talks about cultural factors and that whether cultural specific interventions are actually helpful or not. And it looks like there's research that's kind of ongoing and needed in that area. So sometimes cutting is a social phenomenon that just runs rampant. And especially if you think about like kids in school sometimes, if somebody hears about somebody else cutting, then that might inspire them also to use that as a coping mechanism. So we do have to kind of think about how, how the behavior of one person affects the behavior of others, especially if you're kind of in a close social group, like being in school together or being in a family or being in a neighborhood or a friendship circle, those types of things. So we have to always, again, apply that nursing process. You're probably sick of hearing me say that, but if you do think about the nursing process and really understand the steps, you will be able to understand and accurately answer many test questions just by thinking through what do you do first, what do you do next, and so on. So in our assessment, we always have to be very empathetic. So they're not doing it to get attention. And that's one thing that health professionals have a problem with. We might think, oh, they're just doing it for attention. And so we do have lots of like transference issues. Like maybe that person is just irritating you. They remind you of somebody else, possibly, or, the patient has transference issues. You have counter-transference issues. So we kind of have to look at that. We have to really look for triggers. What is triggering that person to self-harm? So it must be something that is very uncomfortable for them that they just can't seem to tolerate. But if we're not able to drum up some empathy for that person, again, we're not going to be manifesting ourselves in a very therapeutic manner. So that's not going to help patients at all. I know that there are stories about patients coming into the emergency room who have self-harmed, and they get very poor treatment sometimes by the emergency room staff. Sometimes they feel like, oh, they've got better things to deal with, and now, they got really important issues, and people are having heart attacks and strokes and broken legs, and, that's much more important than somebody who just cut themselves because it's seen to be done on purpose or to get attention. And I'm not picking on emergency room staff, so if any of you work in the emergency room, please don't feel that I'm picking on you. But sometimes they really do receive bad treatment. They are made to wait, maybe excessive amounts of time, and maybe somebody else is a higher priority. So I'm not talking about that, but I'm talking about just maybe being made to wait in order to get their cut sewn up or whatever. And then also just being treated very rudely and I've heard where some physicians have refused, if they need to do sutures, some physicians have refused to do any kind of numbing of that area because, hey, they just cut themselves, so why should I numb them, and just kind of inflicting more pain on them than they would to do, if they were sewing up somebody who had a non-self-harm injury. Why would you not have the same type of care and consideration for somebody who is doing an injury for, with a self-harm reason? So many people, even health professionals, do not understand the dynamics behind somebody who self-harms. So certainly some nursing diagnoses are risk for self-harm outcome criteria. We want them to improve their coping, to use different, more effective methods of cope, get some social support, increase their self-esteem. So that would be all goals that we would really want to work on. So in our planning, we have to do some limit setting for safety. We want to help develop their esteem, discovery of their motive and its role. So what are they getting out of the self-harm type of behavior? But again, in a very non-judgmental way. And we want them to discover more ability to self-control and replace good coping skills. You can't just take away a negative coping skill without replacing it with something else. So before that person is going to be able to give up that negative coping of cutting themselves, you are going to have to help them to replace it with something much healthier. So, and then we want them to enter the maintenance phase where that is no longer an active problem, and it's stabilized that they're not actively self-harming. I did read an article once that talked about most people don't self-harm after 10 to 15 years. But if you think about it, that's a really long time to be engaging in self-harm behaviors. Some patients have scars all over their bodies from various cuts that they've had, and many times they even present with scars and cuts in various stages of healing because they're doing it in such a chronic way. So we do want to try to help them to get past that and to be able to cope more effectively and more productively. So we do have to care for their injuries. So it is very important for the nurse not to be judgmental and to be just very matter of fact. Please let me see your cuts. I'd like to see if there's any signs of infection, and let's get a dressing change on that, and put some whatever's ordered for that dressing change, but just to do it in a very supportive way. We don't want to give them a lot of attention around it either. We don't want to say, wow, look at that, that's a really big cut. We don't want to do that. We don't want to give them excessive amounts of attention, but we certainly don't want to be the opposite and be extremely negative and say, oh, look at those cuts, boy, your arm is really disfigured. We don't want to do that either. We just want to be very matter of fact and very supportive. So again, just, let me look at your arm. I'd really like to see if you've got any signs of infection, and let's treat it, and let's get the skin in good condition, and then not give them a whole lot of attention, but certainly not make them feel terrible, about what they've done. So it really depends on us establishing that therapeutic alliance, get that therapeutic relationship with that person, and then we're going to be able to teach them coping skills and have them maybe reflect on their behavior a little bit and try to engage them and talk to them about how do they feel when before they self-harm, what are their triggers, how do they feel after they self-harm, because many times, even though it temporarily helps them to feel better, in the long run they may end up feeling worse about themselves. And many times people that self-harm really do it in secret. They don't self-harm in front of other people. They don't show off their cuts. They really hide them. Some people may end up wearing long-sleeved shirts and long pants, even in the summertime, if they have cuts on their arms and legs that they don't want anybody else to see. So they really can be very embarrassed about some of their behaviors. So reflecting on that is very helpful. And again, that advanced practice interventions would be to provide the actual treatment for the underlying mental health disorder, whereas a staff nurse in the regular hospital is going to just try to help that person to learn other coping mechanisms and to try to understand the triggers that they have and how they respond negatively and engage in those self-harm behaviors. And we always have to look at our look at our interventions and then evaluate the goals that we have for the patient. Are they coming close to meeting some of those goals? So, audience response question: a person with which psychiatric problem is most likely to complete suicide? Personality disorder, major depression, substance abuse, or schizophrenia? So actually, it's a little bit of a trick question. It's kind of a hard question because honestly, people with personality disorders can certainly be suicidal, and some of them do complete suicide, but most of the time people with personality disorders might be more likely to self-harm than actually complete suicide. Major depression, I hope that you picked that. That is the absolute best answer out of the four, because if you have major depression, major depressive disorder, that is absolutely a huge risk factor for suicide. Substance abuse and schizophrenia absolutely can contribute towards people committing suicide. In schizophrenia, we haven't gotten to that learning plan yet, but sometimes when people have command hallucinations, sometimes they are listening to those hallucinations or listening to that voice. That voice tells them they're no good and to kill themselves. And if the voices are really strong and they don't get treatment, sometimes they do follow what the voices tell them. But the actual numbers are going to point more towards major depression. Many more people with major depression will commit suicide than other types of disorders. But not to discount and say that, oh, none of those other issues could be a problem, because they definitely are. And I think this might be the last slide. So again, which method of suicide has the highest lethality? Ingesting pills, cutting your wrist, inhaling natural gas, or a self-inflicted gunshot wound. So I'm really hoping that you picked the self-inflicted gunshot wound. And that is something that we have to think seriously about on the inpatient unit. And they always ask if a patient has guns in the home. And they do try to get those guns secured. And at least most of the time they try to get them completely removed from that person's home before they're discharged. Even if they're better when they're discharged. Sometimes research has shown that if you remove a possible means to commit suicide, that is more likely to keep that person safe. So it's a really kind of a difficult topic, and again, we're going to be talking more about that also in clinical, and suicide may come up also throughout the rest of the learning plans because it is a risk factor for other illnesses that we're going to be talking about too. So basically, this is the end of Learning Plan 3. I will see you in Learning Plan 4.